So next is obstructive defecation, another very high yield scenario for exam. So a 40-year-old lady referred by the GP is having problem with defecation, and sometimes digitation per vagina is required to help to evacuate. How will you assess her in the clinic? So I will take history about bowel habits, consistency of her stool using Bristol stool chart, starting from 1 to 7. 1 is constipated, 7 is diarrhea. Asking whether she strains that stool, whether there is a feeling of incomplete evacuation, post-defecatory soiling, and the need for digitation either per rectally, per vaginally, or perineally to help remove the stool. I would also ask about her obstetric history and whether she has had a previous gynecological or pelvic surgery like colposuspension. This is probably a rectocele, which is not usually painful. Rectocele is a bulge on the anterior or posterior rectal wall. The most common is anterior rectocele, when the anterior rectal wall bulges through the rectovaginal septum, and is a common injury sustained during the childbirth. I would perform a rectal exam looking for a perineal descent, prolapse, and feeling for sphincter tone and presence of rectocele anterior or posterior. Perform a rigid spermatoscopy to look for the presence of interception. How would you investigate this lady? I would perform an endoscopic examination, flexible spermatoscopy or colonoscopy to rule out underlying neoplastic lesion. I would perform a colonic transic study by Nehan's method, that you let the patient take 10 radio opaque foreign bodies each day, and then do X-ray on 7th day. If they have more than 20 residual body on the X-ray on 7th day, they have a slow transit constipation. Or you can calculate the foreign bodies, multiply with 2.4, and if it's coming more than 48 hours, then they have a slow transit constipation. And then third is MR defecography or defecating proctogram. MR defecating proctogram is useful to exclude other causes of vascular defecation like internal intussusception and to assess the rectocele and for an enterocele. You find an anterior rectocele. What are the treatment options? Initially, I would start with conservative measures, such as if she is constipated, I will give laxatives, and if she had incomplete evacuation, I will give suppositories and dietary manipulation and biofeedback. If that failed, the next step would be rectal irrigation. If no response is seen with this, I would discuss the patient at pelvic floor MDT to determine further treatment. Surgery is an option performed by the gynecologist or colorectal surgeon. There are several routes: transvaginal, transanal, or transabdominal. So transvaginal, they can repair the posterior repair, and transanal, they can do the STAR procedure, that's a stapled resection, stapled transanal resection of the rectum. And transabdominal rectopexy, this is VMR, laparoscopic ventral mesh rectopexy. These techniques use suture plication, mesh reinforcement, excision of redundant tissue, and fixation of the rectum, vagina, perineal body, and reinforcement of the pelvic floor to repair the rectocele. Describe one surgical technique that you might use in your practice. So one is the transanal approach, the STAR, stapled transanal rectal resection. It is similar to staple hemorrhoidopexy. It is necessary to exclude the enterocele prior to surgery. If one is found, it should be repaired preoperatively by a gynecologist or laparoscopically in conjunction with other STAR procedure. Put the patient in Lloyd Davis or prone jackknife position and insert an anal retractor. Purse string switches are placed in the anterior wall, 1 centimeter apart and 4 centimeter above the dentate line, and anteriorly full thickness, posteriorly only mucosa, and the staple gun is inserted. The purse string is tightened and the gun is closed. So ensuring the vaginal wall is clear before firing by performing the vaginal examination, and then fire the gun. What are the complications of this technique? Sphincter damage and incontinence, stenosis, bleeding, urinary retention, perineal pain, rectovaginal fistula, pelvic sepsis, and long-term anal pain and tenesmus. How would your management change if she had a high-grade internal interception? So for high-grade internal susception, I would discuss this patient in the pelvic floor MDT and refer to a pelvic floor surgeon. A laparoscopic ventiloscopy would eliminate the interception by fixation of the lower anterior rectal wall to the sacral promontory, as well as correction the associated rectocele. A ventral mesh rectopexy should only be considered in this situation if the patient has a failed full conservative treatment and has been discussed in the pelvic floor MDT. The patient needs to be fully counseled regarding the procedure and the use of the mesh. The Oxford Pelvic Group reported success rates of 75 to 80% in patients with obstructive defecation. Avoiding posterior mobilization of the rectum preserves the autonomic nerve supply to the rectum, thus avoiding the post-operative constipation traditionally seen with posterior suture rectopexy. Thank you.